Well, everyone's nice and quiet, so I guess we'll get started. I was going to wait till 7:31, but you guys are ready to go. So welcome to Surgery Grand Rounds. I'm Kathy Van Leeuwen, the Associate Surgeon in Chief, and I have a really special guest today that really checks a lot of boxes for our teams. Dr. Mary Fallat is kind of a legendary, iconic pediatric surgeon. She gave my pediatric surgery boards. She gave Mark Molitor's surgery boards. She specializes in multiple things that our hospital has sort of modeled her care. She's a trauma specialist. She's a specialist in differences of sex development and colorectal surgery, which is another one of our programs. And Mary's really been a mentor for me for years and years. When I became a pediatric surgery boards examiner, Mary and several other of the women sat me down and said, okay, what's your deal? Let's hear all about you and let's make sure you set your life up properly. And one of the other things that she was invited to do here is meet with our Women's Surgical Collaborative. The Women's Surgical Collaborative at Phoenix Children's was started by Dr. Osley and myself and some of the women, core women surgeons. It's been amazing. It's kind of led by Dr. Kernick and Dr. Grimsby, but it's really a collaborative of all the really talented women surgeons at our hospital who kind of get together and establish community and just really help each other stay here and thrive. And it's been a really wonderful thing. It's kind of spilled over into anesthesia and medicine. So really, Mary, we have been making her meet with every single group that I just mentioned, and we could not be happier to have her here. So I really want you guys to give a very warm welcome to Dr. Mary Fallat.
Well, thank you and good morning. And this is an ambitious lecture. But what I'm going to do is take you back in time to the early years of trauma and emergency care. And since I'm old, I'm going to interweave that with where I was at the time and how it's impacted my career. And as you're watching this, I think you will at the end agree that some things have stayed the same and not really made much progress, which is unfortunate. But there are themes here that repeat themselves. So I have grant support from HRSA for EMS for children, which I've done since 2004 as the PI for the state. And that's really where a lot of my interest in EMS care began. And now I'm one of the sub-principal investigators for what's called the Pediatric Pandemic Network. However, this content is the responsibility of me and not of HRSA. So we're going to talk about three things. We're going to describe the challenges of achieving what's called pediatric readiness in the United States, both in hospitals and EMS systems and what that means. And then we'll describe a framework as well as a system of care for children's emergency care in the country. And many of you probably weren't even born when all of this started, but patients who needed to go to hospitals used to be transported by hearses. And in 1966, we first revolutionized the way that we look at injury, recognizing that trauma was something that victimized many of our members of our population, both children and adults. And in 1973, we brought the ambulance system to the United States, and it was federally funded, which was good because it helped people recognize that ambulances were important to get people to hospitals and hearses weren't really the way to go. And it was the first funding for emergency medical services. And in 1976, they published the first optimal resources document for the injured patient. So this was the Committee on Fractures, now the Committee on Trauma for the American College of Surgeons. And they are the really leaders in trauma care in the country in terms of developing standards for trauma centers and trauma systems. Sadly, in the 1980s, EMS came out of the federal system and went into state preventive health block grants. And that's why we currently have such a potpourri of EMS systems across the country, which are funded now by block grants directed by the state. So some states are very system oriented and some states have EMS systems each do things differently. They don't have a protocol for the state. So things are very different in each state across the country. I was an intern in 1979. I went to Louisville, Kentucky to train under Hiram Polk and David Richardson. David Richardson really was the person who influenced my trauma career. I finished my residency in 1985, and then I headed to Washington, D.C. to become a pediatric surgery fellow. At that time, I was one of few women in surgery and even fewer women in training in pediatric surgery. Of interest, in 1980, the ATLS course was introduced, and I was a second-year resident. I took one of the first ATLS instructor courses and became an instructor during my residency. And in 1985, the year I finished my residency, Injury in America was published. The National Academy of Sciences, now the National Academy of Sciences, Engineering, and Medicine, and at one point it was called the Institute of Medicine. This is the place where think tank people get together and try to look at long-range goals for our systems in the country. And so this was one of the first documents that really, again, put trauma on the roadmap. And then in 1987, the year that I finished my fellowship, Trauma Center Verification launched through the American College of Surgeons. So you're a level 1 trauma center here, and that's a program that's verified by the college. So this is me in 1987. I'm finishing my fellowship. Marty Eichelberger was one of the people who trained me in Washington. He created Safe Kids, if anybody is aware of that injury prevention program. During my surgery residency, I'd done a whole year of trauma out of those 5 years. And in Washington, D.C., they already had a pretty well-developed trauma system, trauma center, so lots of trauma in Washington, D.C. And so I came back and I decided that we needed to start a trauma center in Louisville, Kentucky. And so I got my friends from Washington to come and help me develop a plan. I asked the hospital for a lot of money. They gave it to me, which was even better. And we developed one of the first pediatric trauma centers in Kentucky. This was another grant in 1990 that actually was associated with money. So states could ask for money to develop a trauma system. And this was how Maryland, so MIMS, which is one of probably the best systems in the country, got their money. Illinois was one of the first states. So this is where trauma care systems first got their funding. So 3 pediatric surgeons who are really influential in trauma. On the left is Dr. Haller, who was in Maryland. So this is where the first trauma system was developed. So he was a champion for pediatric trauma systems. Marty Eichelberger, as I mentioned, Safe Kids. And then this is Joe Tepass, who developed the first National Pediatric Trauma Registry and the Pediatric Trauma Score. But what they had in common is that they were all on the Institute of Medicine committee to look at emergency medical services for children, which is the little book you see to the right. And that was published in 1993. Of interest, the initial legislation to create EMS for children came out in 1984, but it took this report to sort of get things charged up and to get some funding for EMS for children. And partnership grants started a few years after the report came out. And this enables every state in our country to have a grant to make sure that that hospitals and EMS services in a state are prepared to take care of children. And there's sort of variable progress with that across the country, but you see in 2005, performance measures were implemented. So the federal government sort of said, oh, we're giving all this money to all these people, but we don't know what they're doing with it and if they're making any progress. So they developed performance measures that we have to attest to as we go through the grant cycle. But this has been continuously funded now since the early 90s. In 1996, the EMS agenda for the future sort of tried to merge EMS into a common vision, laid out 3 areas for change, and periodically the EMS agenda is updated by a group of experts across the country. But we'll talk a little bit more about EMS in this slide. So EMS is not an essential service. It was created as a transportation service to deliver patients from one place to another. You and I know that EMS does a lot more than that now. They deliver medical care. Did you know that if they come to take a patient or to evaluate a patient and they don't transport the patient, they just deliver care at the scene and the patient isn't transferred, they get no money? So it's really a terrible problem, and it has not advanced through the years. The essential services are fire, food, medical care, things like that, but EMS is not an essential service. That's why they suffered during COVID. There's no uniformity across states, as I mentioned, and paramedics who work for fire services, which is an essential service, but are not licensed ambulances, deliver BLS care as first responders. So there's all these restrictions and details that are hidden to most people. So pediatric trauma system development really started in the late 1990s. Richard Mullins was actually one of my attendings when I was training in general surgery. And then he went to Oregon to become the trauma medical director in Oregon. And he had a conference in Skamania where he brought together all these leaders in trauma care to discuss how to move forward. And my friend Frida Holka was the first surgeon to do a study in pediatric trauma system development. Oregon was one of the first states to have a trauma system. And at that time, Washington State, which now has a very fine trauma system, did not have a trauma system. So they looked at the differences between the two states and found that the risk-adjusted odds of death for seriously injured children was significantly lower in Oregon than in Washington. Again, Oregon having a well-established system of care for patients, in Washington not having that. So the first data that also in children, it was important to develop a trauma system. So fast forward a couple of years, 9/11 happens. And I'm not going to talk about 9/11 except in the context of what it prompted. So it prompted a lot of people to get together and try to understand where the country stood in terms of disaster planning. And in the book on the left, published in 2002, they actually looked at trauma system development across the country and recognized that we were not ready for disasters. And on the right, also of interest, was this trauma leadership forum put on by the American Trauma Society. And David Richardson, as I mentioned before, had done this survey of general surgery residents across the country to find out what they thought about trauma care as a career. And of interest, the residents loved trauma care during their residency, but had no interest in doing it when they got out because, it was at that point mainly transitioning to non-operative. It was a lot of night work. It wasn't operating. And so ultimately, you'll see as we go through this that acute care surgery as it exists today was born at this point when David did that survey, recognizing that people weren't going to take care of trauma patients when they got out. They didn't want to do it. It, didn't make much money, and it was an operative surgery. The other thing of interest is the avian flu virus surfaced in 2003. So just think about where we are right now. And I was the chair of the EMS committee for the Committee on Trauma. So they nominated me to go to these meetings, conference calls, about what the country was going to do about the avian influenza virus. So I was on calls with all these emergency doctors and advocacy committees. And so the country put a bunch of money into preparation for this, but they also put it into anthrax. So you remember this is about the same time that white powder was showing up in envelopes and people were opening them. So there's this huge anthrax scare. And it did lead to preparation for such events, but really not for trauma care. And then since we didn't really have any pandemics or issues right then, it sort of died down and people forgot about it. So, people accentuate their interest when there's a problem, but then when nothing happens, then all of that sort of goes away and is subliminal again. So in 2004, there was a effort by the Institute of Medicine to look at the emergency care system in the United States, recognizing that it was problematic. I was privileged to be on the pediatric committee. There was an EMS, hospital-based, and a children's committee. And then there was a cumulative report. And so prior to that time, there'd been this look into what were the gaps. So the gaps were minimal disaster preparedness training, poor access to personal protective equipment, hospitals lacking the ability to absorb any significant surge in casualties, and an inadequate surge capacity for the critically ill. Sound familiar? So this group of people got together for 2 years. We had several meetings, and the important things that came out of it were that there was ED overcrowding. People were boarding in the emergency departments, fragmentation of care. There was a shortage of on-call specialists, a lack of disaster preparedness, and lots of shortcomings in pediatric injury care. And many recommendations were made. But the themes were that we really, as a country and medical experts, needed to try to understand how to improve hospital efficiency and patient flow, develop an accountable system, increase resources, and address pediatric concerns. I particularly liked this statement: a system struggling to meet the day-to-day needs of the public will not have the capacity to deal with a sustained surge of patients. This is the core definition of readiness. And as we'll talk about, pediatric readiness was really born out of this emergency care program. In terms of children, the variation in preparedness was described as uneven. At the time, only 6% of emergency departments in the country had needed supplies deemed essential to take care of kids. Half of hospitals had 85% of those. There was a lack of care coordination, lots of geographic disparities, and many providers undertreated children. They were afraid of them. They didn't know what to do. They didn't ask for help, and many failed to recognize cases of child abuse. In 2007, this study was published. It showed that care at a trauma center lowers by 25% the risk of death for injured patients compared to treatment received at non-trauma centers. It was considered a very important study. The primary authors were Ellen McKenzie and Fred Rivara. Fred Rivara was at Harborview. He became the editor of JAMA Peds and then JAMA Open. Children were not included in the study population. Again, a theme that repeats itself over and over in history is that children were an afterthought. Even though they're nearly a quarter of the population, they weren't included in many of these major studies, early studies that looked at system development. As I mentioned, the discipline of acute care surgery was a response to a need. It was excellent training for rural surgery, for military surgery, and probably most applicable to regionalized acute care centers and trauma centers, because what it's evolved into is that those individuals take care of trauma patients, but they also do acute care surgery. So they get a mix of operating, but also taking care of trauma patients. And so it really has become a specialty that's been embraced by many general surgeons, and it's shift work, which is also what the country is moving to in terms of being able to have a better quality of life. So what did we learn during COVID? Well, first what did we learn and not do anything about? The first is that it's essential to plan for future pandemics that last a year with multiple waves. And even when we planned for H1N1 so long ago, the expectation was that it would spread across the country slowly, giving stockpiles of healthcare supplies time to catch up, which wasn't what happened with COVID. And during a pandemic, our ability to respond to and care for patients outside the pandemic is problematic because we stopped doing regular surgery, right? So all those patients had to wait for their elective surgery because we couldn't take care of normal people while we were taking care of patients who were sick. The pandemic also showed us how deep the US philosophical and political divide is and how it directly and dramatically affected our ability as a national healthcare and EMS system to respond to a large portion of the public simply refusing to abide by medical scientific advice and guidelines. And I probably don't need to tell this audience that things are likely to get worse in the next few years. In the hardest hit areas, COVID overwhelmed emergency departments for an extended period. There was prolonged patient turnover. Patients were staying in ambulances because there was nowhere where to take them so that they could have a bed in an emergency department. And remember, I told you the EMS system is not coordinated across the country. So there's no national EMS office that was able to coordinate a response across the country. And that is because EMS is not an essential. And that remains in place today. EMS is undervalued and overworked. The average salary for an EMT in the United States is around $36,000. They do hard work. They lift heavy patients. They take them up and down stairs. There's a lot of occupational injury. There's a high rate of suicide in EMS. And the training requires an essential curriculum, but not an advanced degree. So we need to be advocates for EMS providers, thank them for what they do. There is a National EMS Advisory Council that was formed. I was privileged to be on it for 6 years. It is an appointment, a voluntary appointment, but an appointment by the Secretary of the Department of Transportation. We wrote advisories, and the advisories were then sent up to FICOMS, which is a federal committee appointed by the government. They would consider those advisories and then decide whether or not they would fund them. So we did all this work, and it was good work, and it was intellectual work. The problem is that when I, as somebody who serves loyally for 6 years on this committee, go and try to see what the return on investment was for my time, I can't find anything. I can find the advisories that I wrote. I can pull them up, but I don't know what happened. I don't know if any of them were ever funded. And, I've sort of suggested that the government might want to help us understand how these appointments actually return investment, not only for the individuals who serve on the committees, but for the public, which we are trying to serve. This is another couple of documents that are in play right now. One is called a National Trauma Care System, Zero Preventable Deaths. Some of you may have heard of that. It's trying to capture the virtues of the military and combat and how that applies to the civilian trauma service, but also to maintain the skills of the military during times when we are not at war so that they are able to take care of trauma patients. And that is a challenge. It's called the military civilian assimilation. And then on the right is this National Trauma Emergency Preparedness System, or the NTEPS document, which is now in version 2.0. This has 12 chapters, and children are mentioned 3 times. One is in a reference. I asked the person who wrote it, who was on the committee representing children, and I got a blank stare. However, I have assimilated myself now into this process because you can crosswalk this document and you can integrate children, but we need to be at the table when these things are discussed, because children may not go to war, but they are secondary victims of war. So, when soldiers go across and enter a war zone, children come to their medical tents to be taken care of because that's the only medical care there is. And then there's very poor preparation for them to be able to do that. So why emphasize trauma when infectious disease seems to be so prevalent in the news? And we just went through a pandemic and then a triple demic, and now we have measles to look at again. So I just wanted to remind you that injury, including firearm injuries now, which have taken over as the primary reason that kids die, are the most common reasons that children die in this country. And infectious diseases is not even on this graph. And sadly, firearm injuries have overtaken motor vehicle crashes as the leading cause of death in this country. And one thing that learners here, the students, residents need to recognize is that you have to scrutinize these papers and see what age is covered. Because sometimes it's 0 to 14, sometimes it's 0 to 19, sometimes it's year 0 to 24. And we're never going to solve the problem of what is a child. And so many of these papers include different age groups, but the blue line there is the oldest age group. It's 20 to 24, and the yellow line is 15 to 19. Many of these are suicides, but certainly firearm injuries is a problem in the country. Over 1 million people died of COVID in this country, and only 0.16% of those were children. On the right, you see a graph that represents how other causes of death went up during the COVID pandemic. Firearm injury went up, overdoses, car accidents, child abuse, burns. And in fact, there are 20 deaths each day in this country from injury. Yet we get very little of the funding in this country devoted to injury. Let's talk a little bit about access to care. This is a map looking at the US hospitals that have emergency departments open for business. There's about 5,200 hospitals in the country with emergency departments. This is a graph that looks at where we have trauma centers and burn centers. On the left is burn centers. Not all of them take care of children. On the right, or upper right, is level 1 and 2 pediatric trauma centers. Lower right is level 3 and 4 adult and pediatric trauma centers. In the middle, lower, level 1 and 2 adult and pediatric trauma centers. And then again, the graph of all hospitals is in the lower left. So you can see that there are large expanses of geography in our country where there are no upper level trauma centers and no pediatric trauma centers. But there is an opportunity, if you look at level 3 and 4 trauma centers, to improve the knowledge in pediatrics so that those hospital emergency departments would be better equipped to take care of children. And that's called pediatric readiness. Pediatric readiness is ensuring that every EMS agency and emergency department has the pediatric specific champions, competencies, policies, equipment, that the equipment works, that people know how to use it. And it's a program that was developed probably 20 years ago, but it's only now coming to the attention of surgeons. And there have been 2 major surveys that have been deployed across the country in the country's hospitals. A perfect score is 100, and it's based on all those domains you see on the right side of the slide. So all of those are assigned scores. And there's something called a pediatric emergency care coordinator, or a PEC. If you have a nurse PEC and a doctor PEC in your emergency department, that's 10 points. And those are the people who really have said, this is important, I'm going to make this part of my job, and I'm going to make sure that the QI is also done for those pediatric victims that come in. And it's probably no surprise that children's hospitals are 95 to 100, but most hospitals that are rural are going to be more around 70. And the national average is 70. Why is that problematic? Well, over 80% of children or 80% of children who are ill or hurt are seen in general emergency departments because they don't live close to a trauma center. 70% of these emergency departments see less than 15 patients a day, which means that the average clinician seeing a child really doesn't get that repetitive need, repetitive ability to see children and take care of them where they have a comfort level for that. So that's why pediatric readiness is important. And probably most of you didn't know that only 8 out of 100 EMS runs are children. So it means that the average EMS provider also has a low level of experience in taking care of a really hurt or a really sick child, and they're really afraid of them. Of interest, this is a almost parallel study to that trauma system study that I showed you that was published by McKenzie and Rivera. And this is on EMS. And it's basically says that states with poor trauma center access have more pre-hospital deaths, which contribute to higher overall mortality. And this suggests that in these states, improving trauma center access will be critical to achieve zero preventable deaths after injury. So this is why trauma systems are important and why there should be a concerted effort in states to develop that. So pediatric readiness is a stretch goal, because you can imagine that to take those 5,200 hospitals in the country and make them all pediatric ready is going to be difficult. But there are over 70 articles now that provide evidence that pediatric readiness decreases all-cause pediatric mortality, including trauma. However, we also have learned that the score needs to be 93 to achieve that mortality benefit, which again is a stretch goal if the average score right now is 70. So this is a very interesting paper that came out in 2024. It looks at how much it would cost to make every hospital pediatric ready in every state. And the cost would be $207 million. Sounds like a lot, but it's really not a lot when you consider the 4.5 million trillion budget of US healthcare. And they even put out a map that shows how much the annual cost per child resident would be to reach universal pediatric readiness by state. And in your state, it's $2. So it's a pretty low amount, a low bar, but it requires obviously advocacy and then funding and buy-in from hospitals. Development of pediatric ready status for pediatric trauma, burn resuscitation, and stabilization takes place mainly in non-pediatric centers. So that's access to care, pre-hospital care, transport of that patient to a hospital, and emergency departments. And surgeons just need to be part of the team. The emergency medicine team is the one that's going to do the pediatric readiness program and the score. The surgeons are not going to be responsible for that, but we have to be part of the team and recognize its importance. So in 2022, the Committee on Trauma embraced the concept of pediatric readiness. They introduced it as a standard. Right now, it's a pretty low bar. In order to pass and become verified as a trauma center, you have to have done the pediatric readiness assessment, understand your gaps, and have an approach to those gaps. But again, the surgeons are part of the team, and their awareness of this, since we're just in that first cycle of verification, becomes more preeminent when they have to fill out their PRQ and get ready for a site visit. So they may not know what it is until they open the PRQ and read, oh, the pediatric readiness, what is that? And then they have to make sure that their emergency department has actually done the assessment. The other gaps in pediatric trauma care relate to things like TQIP. So remember, things like NSQIP and TQIP didn't have many pediatric metrics. And so ultimately, pediatric NSQIP and pediatric TQIP were born so that those would pull out the children and allow us to benchmark more pertinent metrics for children. So the gap analysis was that adult metrics don't really apply to kids. Most kids don't die. In the pediatric data also in the college didn't include any centers that were adult centers taking care of children, but not verified as pediatric trauma centers. And so Aaron Jensen, a pediatric surgeon in San Francisco at Oakland, published a very nice study that looked at the whole data set, including the data points that adult centers were inputting into pediatric TQIP, but nobody was considering in the benchmarking, and found that 4 kids died at adult trauma centers that were taking care of children. So I think that we, those of you here who are pediatric trauma surgeons interested in trauma, take care of trauma patients, that we need to take up the gauntlet to have more appropriate TQIP metrics for kids, and benchmarking for all centers that take care of kids, not just pediatric trauma centers, but it's got to be bi-directional. So we can't be sitting on our thrones here and looking down on the adult counterparts who take care of children. We have to help them. We have to embrace that we can't take care of everybody, nor does every pediatric surgeon want to take care of trauma patients. And we have to recognize the contributions of our adult colleagues where they're doing this and saving lives, and encourage them to actually get verified for pediatric trauma. I'm going to just show you a few slides about burn care because I am assigned trauma and burns in my domain through my grant. And so last year in Kentucky, I looked at the challenges in children's burn care and decided to try to convene a group of burn care experts to look at gaps and opportunities. And the American Burn Association does burn center verification, but there are lots of children's hospitals that take care of burns and aren't recognized for doing so. And there's very little bi-directional education and communication with burn centers because pediatric surgeons in those smaller centers don't belong to the ABA. And the ABA is where the experts are. And so there's a lack of awareness of where children with smaller burns get care. And there's also a diminishing workforce in burns because general surgery residents don't have to do a burn rotation anymore. So a general surgery resident who is somewhere where there's no burn center can go 5 years and never see a burn patient. And then they get out and they can't take care of burns. And plastic surgeons no longer have to take a burn rotation. So that means that burn surgeons who are older are retiring and nobody's in the pipeline to take their. So another reason that this is really important, because a lot of pediatric surgeons take care of burns at Children's Hospital. So we started with this vision for system planning. I had a committee, their names are listed there. 40 people came to Louisville for what I called a burn think tank meeting. And our little task force had the agenda developed in advance, along with little work groups to talk about all these topics. And potentially to use the Pediatric Pandemic Network and the hub and spoke model as a way to promulgate information about burns, but bring people together. And we've got an agenda. We're meeting again in July of this year. And the ABA has graciously allowed us to have 75 minutes on their program next week in Phoenix. So I'm coming back next week. But I think it's a good thing, but it's, it's again, one of those marathons and not a sprint. And so there is also something I just wanted to tell the audience, especially the learners, is that the acute care surgery fellowships have allowed 2 subtracks to be developed. One is a pediatric subtrack and one is a burn subtrack. To be clear, these are not training pediatric surgeons or pediatric trauma surgeons or burn surgeons, but it means that in these subtracks, the fellows will do more children's care. We'll have certain requirements. We'll have some case requirements, and it will enable the surgeon who will take care of some children during their career, or maybe they're in the military, or maybe they're going to do global surgery, to have more expertise in these areas and to get a special certificate. So the next topic is just looking at trauma system development in the country. The Childress Foundation, funded by Richard Childress, the NASCAR driver, and it's at Wake Forest, gave me $40,000 to do this study looking at pediatric trauma system development. So it took me 4 years. It was a project that was hindered somewhat by who filled out the survey, but it was an extensive survey, as well as my research resident and I going to the web and trying to find missing data. But I had a group of experts who helped with the Delphi process develop the domains of importance for system planning across the country. Each one was weighted. And so each state got a score that was attributed to system development in the state. And your score was 87.5 out of 100. So you did well. And you'll see in the inset on the right that your state is not very rural. So Kentucky, I live in Kentucky. Kentucky's very rural. You only have 2 children's hospitals, but your state is less than 50% rural. Another one of my mentees, Caroline Stevens, was able to take that assessment score and convert it and the data into an agenda, like a blueprint for how a state could address their shortcomings. And that's published in Trauma and Acute Care Surgery. And I now have new funding through HRSA to continue the database. So we're looking at everything post-COVID. We're refining the data points, and we're going to deploy the survey again and see if states have been able to improve their trauma system planning after COVID. These are just some other statistics. So at the time that we did the study, the General Accountability Office had published a report looking at proximity of children to trauma centers. And these are your statistics. So the percent of children living less than 10 miles from a high-level trauma center was pretty high, 57.5%. And the percent living 10 to 30 miles from a high-level adult or pediatric trauma center was 23.3%. So the proximity of most of your population is pretty good to have access to a trauma center. The things where you answered no, which may have changed since the first time we did the survey, there's no written requirement for a pediatric representative on your state trauma advisory council. You did not have a state pediatric trauma destination bypass protocol in place or a public-facing pediatric report for trauma. You answered no to adult trauma center EDs have guidelines for recognition of child abuse. And your state pediatric readiness score was 72.3. In 2021, when the pediatric readiness survey was repeated, you had only a 32.6% response rate. So 28 out of 86 hospitals responding. Sadly, that survey was deployed at the end of COVID, and a lot of people were survey exhausted, and so they didn't fill it out. So I'm not sure that, I don't know what the readiness score was at that point, but it would be good for you to know what the readiness score is for your own hospital. It's probably around 100. Just a sidebar, one of the other interests that I and a group of pediatric surgeons have is what children's surgery is being done in rural America. Why is that important? Because if a surgeon does some children's surgery, they're probably more comfortable going to the emergency department and seeing a trauma patient. So we did a survey some years ago, but recently repeated it. And this is an in-press study looking at rural general surgeons' perspectives. So I was privileged to be the first vice president of the American College of Surgeons, and I asked if I could target rural chapters. And when I went to the chapter, I put up a QR code and asked them to fill out the survey. So over a couple of years, we had 162 respondents. So these are all surgeons who consider themselves rural surgeons. Median age 58, most are male, and a majority of the respondents operated on children, but only performed about 20 operations a year, consistent with their training experience. And the amount of pediatric surgery exposure they had and when they had that training did impact what kind of cases they would do, what ages they would operate on, et cetera. But interestingly, 90% reported they would have completed additional training in pediatric surgery if it had been available during, but not after completion of their residency. So just more months at a later time in their residency program. 3 to 6 months was reported as the optimal duration. And most influential regarding their decision to operate on children was really comfort. They'd done enough cases, the availability of pediatricians and others to help them take care of the children so that they weren't doing it in isolation, and then proximity to us, to a children's hospital, to someone who would give advice and to someone who would support them. Many surgeons in smaller communities do take care of some children, but I think that is declining, partly because COVID forced many smaller hospitals to look at their bottom lines because they were taking care of sick adults and to close their pediatric units because there weren't enough kids and they didn't reopen them. So there are less hospitals now in rural America taking care of children. I think telehealth is a rather unexplored opportunity, but certainly that would enable us to provide better feedback to community surgeons. So what's our future? This just puts into perspective the HRSA programs I've talked about. So emergency medical services for children came out in 2001 and still exists. The EMSC Innovation and Improvement Center uses evidence and evidence base to translate that into what we can do to improve care for children. That was started in 2016 and is in its second term of funding. And the Pediatric Pandemic Network is the network of children's hospitals using a hub and spoke model that promulgate information across the country to help with disaster planning. But really the focus of that is if you're not ready to take care of a kid every day, how are you going to be ready in a disaster? So it's building infrastructure right now for pediatric readiness. So you'll see there in 1997, that's EMSC, when partnership program started. The National Pediatric Readiness Project started in 2012. EIIC opened in 2016. ASPR is another, so that's the Assistant Secretary for Preparedness and Response. They have 3 centers of excellence for children's disaster planning. One is on the West Coast where all the forest fires are. One is along the Gulf, which is where the hurricanes are, and one is in the Midwest. And these are also resources for children's disasters. And then the Pediatric Pandemic Network was created in 2021. And this is where the 13 hub hospitals are located. Those are the red dots, but there are also the 3 centers of excellence. So the blue is where the Western states are, green is Midwest, and the purple areas, the Gulf. So a lot of the country is now covered by children's hospitals or ASPR regions taking care of children's disaster planning. These are some of the things that are being considered by the federal programs, looking at surge, looking at CBRN, so chemical, biological, nuclear, radiation. The threat of nuclear war is probably higher than it ever was. Deployable assets, where those are located, reunification if families are separated, and supply chain. But I think the messaging here is that trauma system development has to include both children and adults from the ground up, and that we need to be part of the team. So one way that you can get involved, the leadership, is to look at model state planning for disasters. When a disaster strikes a state, there are many other agencies that come into play that children's hospitals probably don't impact or interact with every day. And that's emergency management. It's your HPP program through ASPR. The reason that I was able to understand this is because Kentucky has a lot of natural disasters, tornadoes, floods, from deforestation. We were a coal mining state. You know, they took down all the trees and did strip mining, didn't replace the trees. And now when it rains really hard, all of those little small houses in Appalachia that are on mountains wash down mountain. And so we have a lot of national disasters, and the integration of children's interests has become one of my focuses. And on this list is all of the people that we have put on a planning committee for children so that children will be better integrated into the system. The American College of Surgeons is also very interested in having this happen in every state. And so they have asked each state to provide an adult and a pediatric representative to what they're calling RMOC development, which is part of that NTEPS plan that I showed you. So what's an RMOC? It's sort of the unit of action. It is the Medical Operations Communication Center. There are a few centers in the United States that are centers of excellence. One is in South Texas. It's called STRAC. There's another one in the state of Washington and one in Alabama. You probably had an RMOC during COVID. It was where the dashboard was that showed how many beds were available in hospitals, how many ICU beds were occupied, how many patients were on ventilators. Somebody went in every day and updated the data. But all of that sort of subsided when there was no longer a pandemic. And so this would be an effort to make it a daily activity. So when a disaster happens, everybody's poised and ready to update the data. It creates situational awareness for trauma patient distribution and load balancing. So it means that if your hospital was overwhelmed with respiratory patients, but you had lower acuity patients, perhaps they could be moved to other hospitals to make room for the patients who were going to come to your hospital who were victims. There is actually an effort through the National Academy to look at what would we do if we had 1,000 casualties for 100 days per day? Where would we put them? Where would they go? The military system would be overwhelmed almost immediately. Children would be coming to us. You know, our CEOs aware of the fact that we might have an event like this, but it could happen every day. If you watch the news, it could happen every day, any day. And so the conceptual model is at the bottom, you've got day-to-day operations, but you also have to understand what's going on in your region and then your state and then your borders. You know, how many states are on your borders? You're bordered by Mexico also. You could have an influx of patients from Mexico, who knows? But the concept is that the RMOC is the communication center, and we need to be strategized to be better aware of data, best practices, education training, who's going to do the communicating. You know, if you have a disaster, you probably want somebody from cardiac and somebody from stroke and somebody from trauma sitting in a room, and someone from every hospital coming together in a communication center and helping to direct the traffic of the patients. So just to sum it up, the stretch goal is readiness. We're not ready every day. We're not going to be ready in a disaster. And we haven't even talked about public buy-in, public preparedness, or the fact that we relate to a number of other organizations that really need to be our partners in this effort. And for so many years, we've been considered a niche medical specialty, right? Children are an underrepresented population, but we need to be gorillas when advocating for attention and dollars, and we need to be part of the plan. Thank you very much.
Okay, you can go ahead and ask questions, and the overhead mic should pick you up.
Questions for Dr. Fallat? Okay. He's doing a survey.
Do the survey.
I would ask you and Mary to comment, like, what is the FTE requirement to participate in this kind of thing statewide or regionally? Like, what kind of resources our hospital needs to get? Mary, do you know, like, what hospitals that are that model the FTE resources?
So there is a national collaborative through the VPN network, and I do not know if your hospital is participating, but there's 125 hospitals, children's hospitals participating in several modules, and there's a PPN website where you could get more information. And The goal is for those, most of them are PEM, not surgeons. They're pediatric emergency medicine and nursing supervisors. But I think having a trauma surgeon and an orthopedic surgeon on your disaster planning committee simulation, which probably do. And I think as many people as you can involve in simulation is important. So it's not actually an FTE, but it's everybody who might have best interest in preparedness planning for your hospital. What would you do if your elevators work and to carry patients? So if you planned that, there's a document that the AAST put out on preparing your operating room for disaster, which has a checklist. And it includes things like supply chain. So if you had 10 patients with gunshots, do enough trays, how would you get those trays sterilized? Where would you get new trays? What if you needed surgeons from the community to come in and help? Like, who would you call? So it's being prepared by addressing these things in advance. And I think it could be integrated into job descriptions. But Dave will know, I just did a small survey looking at the FTE of pediatric trauma medical directors across the country, and it's about 0.2 FTE. But many of them have no written role in disaster planning in their job description, even though they do some of it. So I was thinking we could come up with language that would put that into the job description to make sure it puts it on the papers.
I have a question. As a general pediatrician, we give vaccines, we deal with infections. That's very political. It seems like trauma should not be political. Like everybody in an arrest state should agree that when somebody's in a car accident, they should have access. Is there any threat to the nationwide resource right now from the political changes?
Probably. We don't know. And when the administration turned over for a while, we were given some directives, but I can tell you that we're now fully funded for year 4, and next year is year 5. I will also say that this grant is meant to be multi-hazard, all hazards. And I felt privileged that trauma and burns were included. Despite the fact that so many children die of injury, we are not as well integrated into the pediatric community. But one of the PIs is a pediatric trauma surgeon. So trauma and burns were actually given fully in the grant. But to be clear, when you go to the website, measles is banned there. But if you watch, it rotates to forest fires. And then there's a place to click on it, and you can find a burn buddy badge, burn resources for children. And there's a whole section on trauma where you can click on it and get the paper, it's open access, just download it. So it's getting better. And there's also a site on a landing site for this, they call it the DNC, but it's changed that, but it's a national disaster national collaborative, the resources that were developed, the toolkits. So it's very robust. And part of the hub and spoke model objective is to the children's hospitals learn it and then promulgate it to their spokes so that the network increases in terms of preparedness. But I think state planning is also essential because a lot of people have no idea who comes together in a disaster to plan where people are going to go and how they're going to get there.
Hey, so Mary, first of all, congratulations on an amazing career and an amazing talk. One of the issues with burn care is that the burn prevention has been so effective that the number of burn children has gone down. And so when we look at Phoenix Children's Hospital being a burn center, there's no way that we can meet the ABA requirements for burns. And it seems like there, and especially with the ABA coming to Phoenix you know, in a couple of weeks. Like, it seems like there should be a pathway for us to take care of more burns than what the ABA is currently recommending. So they're recommending that we transfer almost every burn to a burn center. And there's no carve out for our resources, which are strong, but we're not a burn center. And so is there any discussion, any opportunity for peds for a higher percentage of burns to be taken care of at peds trauma centers without being, the highest level of ABA care?
I spent over an hour on the phone yesterday talking about that very thing. And I think what has been agreed upon is that the chair of the verification committee and the president of the ABA have agreed to meet with a small group of us pediatric surgeons to talk about the gaps that the issues, talk about the issues. And they are very adverse to a tiered system. I've suggested, what about pediatric recognition for burn care? What about just some other level? Because you bring up great points. One is that our pediatric ICU nurses don't really know how to take care of burns anymore. And the pediatric critical care specialists don't really get that in their training curriculum. And so you have to develop a whole tiered approach to learning as well. But there seems to now be at least an interest in meeting with us and talking about it. And to take it a step further, if the ABA were to embrace that second level, there is a data registry that a few of the pediatric burn centers have put together for Pickwick. And I suggested that the ABA might want to look at that and make that their BQIP-P registry, bring it into the ABA, and then they have more pediatric surgeons in the ABA so that the data would be there, the benchmarking potential would be there, and you would have more bidirectional communication between pediatric surgeons providing care and the burn surgeons. So it's in play.
We're gonna let people go, so maybe we can continue the questioning after. Thanks, everybody.